Grand Round series this year to be all online using Zoom. And that's not all bad. It will allow people to join us from wherever you're at, including all of us and all of our speakers. It allows us to meet more often, and we've decided that we will move from a monthly Grand Rounds presentation to a weekly Grand Rounds for this academic year. It will always be on Fridays from noon to 1 o'clock, and it'll be right here on Zoom. We have some really outstanding content planned for this year. We have worked with a great group of faculty to develop plans for our Grand Rounds presentations, and they are in 4 categories. So you will hear presentations this year that focus on innovations in education, on innovations in clinical care, on innovations in research. And we will also have Grand Rounds presentation that focus on staff, faculty, and trainee development and well-being. And we have had a group of faculty, and you see them on this slide here, who've joined us and worked with us to start putting together a really great series of presentations in each of these 4 areas. Some of these presentations are going to come from our own faculty and staff, just like we will have today. And for other presentations, we're inviting national and international experts to join us and share with us. We're going to be archiving all of these presentations and make them available on the department website over time. And I think this will be another nice way for us to showcase some of the really great work you all do here at UW-Medicine and in the Department of Psychiatry and Behavioral Sciences. So I really hope you can join us for as many of these Grand Rounds presentations as possible. To help coordinating this new Grand Round series, I've asked one of our faculty, Dr. Joe Caramelli, who is here with us today, to help coordinate our speakers this year. Joe is going to have administrative support from Semhar here in the chair's office, and I want to thank her for her help with this, and also from Becky on communicating about Grand Rounds, and from Mike and our IT team. So thanks to all of you for helping us make this possible. So now I'm going to ask Joe Caramelli, to make a few comments and to introduce our speakers for this first inaugural Zoom Grand Rounds event this year. Welcome everybody, and hi Joe.
Thank you, Jürgen. Again, as Jürgen mentioned, this is the beginning of our series, and today we'll start the series out with a 2-part presentation by 3 UW faculty members, Dr. Emily Dworkin, Dr. Kristen Lindgren, and Dr. Michelle Bedard-Gilligan. And the 3 faculty will present today and next Friday. This 2-part presentation is on skills for psychological recovery, and will provide us all with an overview of the intervention, and then move on next week to the skills for applying the intervention. And this is an example of adapting a broader intervention, taking components of it to try to expand the reach of it, and translate findings into clinical intervention that we can all use. So I'll stop for now, and we can move on to the presentation. Thank you.
Thanks, Joe. I appreciate it. I'm going to work on just getting my slides up and get us going here. And okay, and hopefully this works. And let me do this. Okay. And just want to confirm that people are able to see the slides. Yep, great. Thanks, everybody. I appreciate it. So to get us started, most of all, I really want to thank Joe and Jürgen for the opportunity to lead off with Grand Rounds, let alone take 2 slots for Grand Rounds. We really appreciate it and really are honored to get to do this, and are really excited about what's happening with the Grand Rounds program and that we get to be part of it. When I think about the topic that we're going to be talking about today, this treatment package, intervention package called Skills for Psychological Recovery, what I hope that we're able to convey to you, and the we here is my co-director, Michelle Bedard-Gilligan of the Trauma Recovery Innovations Group, and core faculty member, Emily Dworkin, who is responsible for not only wonderful content, but all the beautiful artistic work that you're going to see today, is that this is important to us both personally and professionally. And I think about this on a personal level. I am a working mom. I have kids who are going through remote schooling right now, school-age kids, and just really seeing the impact of what the ongoing coronavirus pandemic, let alone other crises that we're facing, including anti-Black racism, increasing awareness of structural inequities, increasing financial challenges that many people are facing, and the ongoing social unrest is making this a really tough time for lots of people. And I'm finding myself using some of the skills that we're going to be talking about today just to keep myself going as a form of self-care. And also as somebody who is a researcher, I think a lot about unmet needs that we have in terms of being able to disseminate what we're learning in research institutions, best practices, best principles, and get it out efficiently into the community so that the community can benefit. And then from the context of thinking about this as someone who's a practicing clinical psychologist and who's working within UW Medicine, of really seeing the ongoing grind that the last 6 months is really putting forth on our patients that we're seeing, and hoping that this will be useful to you in at least some of those capacities. And so what I want to do is just give you a sense of what we're doing over the next 2 weeks. Today, what we want to do is start by giving you an overview of what Skills for Psychological Recovery is, give you a feel for the background behind it as an intervention itself, the rationale for why we think it's important and can be useful for you in multiple capacities, give you a feel for the overarching structure and the first phase of SPR. And then what we're going to do the second week is we'll do a lightning review of what we covered the first week, just so that if folks are coming in only for the second week, that they've got a little bit of a feel for what we're doing. And then we're going to really dig into the skills that one teaches and that one covers with SPR. And so with that, what I want to do is just let you know that SPR is not something that Michelle, Emily, and I created. We are adapting it, and we're providing a primer of a package of skills and interventions that have been put forth by the National Centers for PTSD and the National Child Traumatic Stress Network. The National Centers have absolutely fantastic resources if you do find yourselves wanting to dig into this more in depth. They also offer free online courses that have CE with them, and that's both for psychologists, social workers, and CME for MDs. So something just to be aware of if this piques your interest in something that you want to pursue further. And we also want to acknowledge over the last 6 months, we've had a tremendous amount of support from the department, from Jürgen and from staff, including Molly, Rebecca, and Rosemary, just to develop these kinds of materials and to get them out. And we just want to thank you so much and really appreciate all the efforts that you've been making on our behalf, and to be able to get this information out to the community. So with that said, what we're going to cover today is we're going to talk about the background, and then we're going to move into talking about the components and structure of SPR and assessment. I'm going to start us out, and then about halfway through, Emily is going to pick up and lead us through the remainder of the presentation. We do have the chat function on. Michelle very graciously agreed to handle chat, so please feel free to send questions in as we go through, and we will absolutely allow time for questions at the end. So with that said, let me give you a feel for background for SPR and why it is that we think it's particularly helpful during these times and what's going on for us right now in the United States and globally. Just as a reminder, with what we're facing right now and the multiple crises that we're facing, our standpoint is that what our primary job is as mental health providers, as researchers, as specialists, is to really think about how can we help promote resilience. And we focus on resilience in particular, as opposed to full-blown psychopathology, full-blown mental health disorders, is because, in fact, the most common outcome of crises is resilience, right? So I think there's been a lot of talk about how many people are going to end up with full-blown mental health disorders like PTSD, like major depression, like anxiety disorders, like substance use disorders. And there is not going to be a trivial number of people for whom that happens. That is a real thing. That is going to be a real outcome. It is happening already. But for the majority of people, based on what we've seen with other kinds of crises and disasters, the most common outcome is in fact going to be resilience. And what we really want to do is to be able to facilitate long-term resilience and help people get through acute distress. That's our job. And when we think about SPR, Skills for Psychological Recovery, this in fact is a package. It's a set of skills and intervention that's been developed to help people get through these periods of acute distress that go along with a disaster, a long-term crisis, and to be able to keep people going and really help improve mental well-being. One thing I want to note is that the kinds of skills we're going to be talking about today are explicitly aimed at individuals or families, and they're explicitly aimed at individual factors. And so I want to really acknowledge and state outright that this doesn't replace or obviate the need for systemic and structural support that is also going to be integral to help us getting through this. But what we're going to do today in our role as psychologists, as mental health experts, is really focus on the individual and the individual factors. One of the other things that we want to remind you of as we're thinking about this, and in the context of thinking about SPR as a package that helps facilitate resilience by teaching a set of skills, and this fact that resilience is in fact our most common outcome, is not to say that there isn't distress, right? When we think about resilience, we want to talk about and be mindful of the fact that resilience is indeed variable. It's going to look different from different people. It's going to look different over time, that it's not linear, that in fact what we tend to see over the course of a disaster, over the course of a crisis, is that there are periods of acute distress that happens, and then there's often a little bit of give, and then it comes back up, and then it comes down again. And that what we actually want to do when we're facilitating resilience is to help people basically come up with that and be able to hold along with the effort, the persistence, the patience to get through these periods of distress that they're going to be facing. And most importantly, what we want to stress, and what the research literature is really clear on, is that resilience is not an innate skill. This is something that can be acquired. This is something that can be learned. So those of you who may have familiarity with growth mindsets and the idea that the meaning we make of a trait, an ability, really has impact for what we do, the meaning we make of resilience is also important. And we want to be really clear that from the standpoint of the scientific literature, resilience isn't all or none. It is in fact a skill. It's something you can get better at. And so what SPR is intended to do is really help facilitate resilience. I also want to give you a little bit of a feel for what we're starting to see in terms of actual data in the context of life in the United States since the pandemic began. The data that I'm showing you here is coming from APA. This is the Psychology APA. And it's showing monthly data about stressors and stress levels. And I think the big picture in terms of orienting you towards what you're going to see is that the data are indicating a trend toward resilience. Remembering that resilience still includes distress, but the idea that most people are getting through it and learning how to tolerate it. The data that we're going to be showing you here is from Wave 3. This is going to be data that was collected from June to July 2020. And so keep in mind, this is the challenge that we face in terms of looking at data. Things may look different now, likely do look different now, but this is what we were looking like in June and July. And again, samples about 3,000 adults. So what you're going to see over time, which I think is interesting, is that we are seeing that while Americans' reported stress levels are still high, they are in fact lowering over time. So putting in context, what we're seeing is that the stress is still high. It's coming down over time. And I think the interesting thing is that if we go forward, we're seeing that stress is waning in the Northeast. So we're seeing some geographic differences, but that stress is rising elsewhere. And again, this is kind of tracking some of the things that we've heard about over time. And so if we think about the fact that distress about getting coronavirus is waning in the Northeast at the time, the Northeast had just come through their big surge in cases that they had had. And the Midwest, the South, the West, these were places that wasn't getting to yet. And so again, we're seeing the places where the distress was, where the acute stress was and was fading, then we're starting to actually see reductions in stress that people are feeling. I think another big picture piece that we want to be aware of is that the kinds of stressors and challenges that people are facing is not just about COVID. And we alluded to this earlier. This is really a unique time, not just for the US, but globally. When we think about the US, we're thinking about an incredible amount of uncertainty and unpredictability when it comes to social and political factors. We're thinking about increasing awareness of anti-Black racism, increasing awareness of structural inequities, and we're seeing that the stress is high across the board. I also want to give you a feel. I wear a hat as an alcohol researcher as well, and thinking about as stress goes up, what does this do to our coping strategies and how much we're using substances as a way to cope. What you're seeing here, these are some data that are coming from a study from RTI. They have a study on alcohol consumption during the COVID-19 pandemic. These data here are coming from adults. They were collected in May and asking people to look back at their alcohol consumption in February and April and documenting changes. Again, what we're seeing here is that we are seeing increases in alcohol consumption, including excessive consumption. And a couple of things that I want to highlight to you for us to be thinking about in terms of ourselves, in terms of our colleagues, in terms of the patients that we're working with, in terms of our larger communities, is that the largest increases that were observed in these particular data were actually hitting the Western United States. And so we are part of the Western United States. So we are definitely seeing the impact of that stress. We're also seeing, and this is consistent with where we're seeing the impact that's happening financially and in task shifting, is that some more than others are really bearing the brunt of the pandemic and of the structural changes that are happening as a way of addressing the pandemic. So women, people who identify as Black, people who have children in the household, they are those who are also are demonstrating the largest increases in risk. So this is an important thing for us to think about. Much like anything else, we are not being affected by what's happening equally, and some are suffering more than others. And we want to be aware of that and make sure that we can get help to those individuals. And finally, the last thing I want to highlight, because I think this is important in terms of really thinking about who do we need to help, where do we need to help facilitate well-being and facilitate resilience, is that what these data are giving us some indications about is that when we're seeing this increase in alcohol consumption, this increases in drinking risk, it's not actually, the largest increases are happening among individuals who were not previously having problems, right? People who are not typically drinking in excess in the past. So this is interesting that this is a relatively novel group, if you will, that is potentially feeling more distress, making more use of alcohol as a way to cope, or just the availability of alcohol. When we think about what's been shut down, what hasn't been shut down at various times in the United States, that this is a part that's happening as well. And so with this in mind, we really want to be thinking about, how do we continue to facilitate resilience? How are we going to help people get through this? From a big picture standpoint, I want to alert you to the fact that there are different approaches that we can use, different things that we do, depending upon where we are in a period of crisis, where we are in the period of a disaster. It's going to depend on early versus late stages. And so you'll see when we think about this as psychologists, often that very early stage would be psychological first aid when we are in that very early initial acute stage of a disaster just occurring, moving down to skills for psychological recovery as we get into a more chronic stage. And then you'll also see CBT for mental disorders, maybe something that's more appropriate when we're in that chronic stage and for individuals who are really having tremendous difficulties and not responding to brief interventions, or who just present at a much more acute level right from the get-go. We also want to acknowledge when it comes to SPR and psychological first aid that they're a little bit different than many of the psychological treatments that we think of for addressing mental health concerns. CBT for mental disorders, we would view them as evidence-based, meaning that we've got lots and lots and lots of RCTs that have tested CBTs for various problems that are happening. In contrast to SPR that we're focusing on today, we describe as evidence-informed, meaning that what has happened and how this package came to be developed was to really look at the kinds of problems that people were having in these kind of chronic phases of disasters, and what are the kinds of skills that we know from other interventions that are helpful for them. And so it's considered to be an evidence-informed approach. My guess is that we're going to see this become more of an evidence-based approach as we have more clinical trials and more data that actually evaluate SPR. But the evidence base is actually pretty thin right now. And if we think about it, it can be very challenging to collect data amidst disasters. So as we think about SPR, and we think about it as an intervention to promote resilience, you'll see this in the explicit goals that SPR has, right? So SPR is assuming that individuals who are receiving this as an intervention are already stable, meaning they're not in acute crisis. And it's intended to really provide multiple sessions of skills building. And the multiple sessions of skills building, we're not talking 20 or 30 sessions of skills building, we're really talking 1 to 5 sessions of skills building. And what we're wanting to do is to really protect mental health, really thinking about this as not addressing full-blown mental health disorders, but really promoting and protecting the mental health that individuals likely already have, but is being disrupted right now. We really want to enhance survivors' ability to address their own needs, and we want to help teach skills to promote their recovery. And SPR is a pretty broad intervention. The really lovely thing about it, and part of why we begged and pleaded to be able to take 2 sessions to go through this, is because SPR can work for individuals across the full range of development. So SPR can be adapted for children, for adolescents, for adults, and for older adults, and can also be used with families as well. And the goal really is to prevent maladaptive behaviors and to identify and support people's existing strengths, their existing adaptive behaviors. And big picture, why we think about SPR, why we're excited about SPR, is that this really is this lovely way to help build capacity, right? We know that there are going to be these periods of acute distress, and what we want to do is to really promote skills that can help facilitate people's resilience to the surges that they're going to have, so that they can face these surges with tolerable levels of distress, right? And so if we think about this as much more of a public health style intervention, this is the way to teach skills, get it out broadly, and help people really kind of buttress this, the distress that they're going to be facing. As we alluded to earlier, SPR isn't a treatment for mental health disorders. So in terms of how it was originally designed, it wasn't designed to be therapy. This is not CBT for anxiety, for example, or CBT for depression. It's not focused on pathology. It really is focused on building skills and really promoting mental well-being. You'll notice that it's quite different. This is not psychodynamic or psychoanalytic exploration. This is present focused, skills based, kind of the quick and dirty ways of helping people. Similarly, it's also not debriefing, psychological debriefing, which might be familiar to some as an intervention that at times gets used during disasters or traumatic events. One of the reasons why we're excited about SPR and think it can be useful is that it certainly can be adapted for use within a specialty context, and it also doesn't have to be done by highly trained specialty mental health providers. This is something that even lay people can do as long as they have some basic training in mental health. So again, we see this broad possibility of dissemination. So pulling this together, what we want to kind of give you a feel for is that SPR can be useful both for patients and providers within our own context. Ways that Michelle, Emily, and I have been thinking about SPR being useful, and ways in which, frankly, I've started to use SPR even in my own practice. I have some existing patients who are coming back and wanting some booster sessions, people who have completed treatment, sometimes even several years ago, and they've contacted me, gosh, I'm really having trouble coping right now, I need a little support. SPR is something that certainly can be used in the clinic. Though it's not designed to be its own therapy, it can be used as therapy if you need to, just as a way to boost those skills. It can also be used for existing patients who need extra support and structured support. If we think about people you might be working with in a psychodynamic or psychoanalytic frame and they're having difficulties, this is something that could be woven in, or taking a pause for a few sessions as a way to get them through it. Those of you who might be doing medication management with a patient and notice that they're having trouble coping, this is again something that can be folded in and be done briefly. Some of you also may have may do consultation and be thinking about patients who are non-specialty clinics. Again, SPR is pretty flexible and can be implemented in those kinds of settings as well. I also want to alert you to the fact that it can be useful for providers, right? So many of us right now are feeling the effects, right, of this ongoing crisis that we're facing. This has been a long road that we've been navigating. And I think in particular for people who are providing support in a professional capacity and also who are undergoing and living through these experiences, we ourselves might be wanting some extra support. We might be feeling burned out. We may have questions in our own private moments about how we're going to make it through. These kinds of skills are very useful. They can be done in a self-help capacity as a way to just provide support for you and for yourself to get through it. It can also be helpful for colleagues of yours who are non-specialists and may be wondering what they can do, or also how they can help their own patients. And that's another way to think about how SPR might be useful to you in your own capacity. We alluded before that SPR is best understood as an evidence-informed intervention. And what we mean by that, again, is that the principles and techniques that we're going to be introducing to you today and next week are drawn from research. You know, what is it that we know that's effective in terms of addressing people who have gone through trauma? What are the techniques that we know that are effective for reducing people's risks and promoting their resilience? That's what these are coming from. These, again, as we've alluded to earlier, the nice thing about SPR, why we're really excited about it, is it's super flexible. It's applicable to lots of different kinds of settings. It's applicable to people across the lifespan. And I think crucially, it is very culturally aware. Any of the skills that you do can be adjusted. This isn't a one-size-fits-all therapy. There's general principles that you can use, but this is done in a collaborative fashion with the person that you're working with. It might be a patient, it might not be someone who's formerly a patient, but they can be adapted based on people's own culture, their own values, and what's going to work for them and the community in which they're living. Just to give you a little bit of feel for how SPR is received and perceived by providers, this is some data from the aftermath of some of the wildfires that were happening in Australia, where SPR was rolled out. And one of the things that's really nice is that you'll see on the left hand side of the slide, variety of the different skills that come up with SPR. And one of the really nice things about it is that providers who were taught and who used SPR really found that it increased their confidence and they found it to be useful to them. And caveat I want to give you as we're thinking about SPR is that right? It's appropriate for many people, which is why we're excited about it, but it also isn't appropriate for everyone. And I just want to give you a feel for, you know, what are the situations, what are the kinds of cases in which you might not want to use SPR? So places where we think about where it's not necessarily appropriate, it is appropriate for people who are in a chronic phase of a crisis, but if somebody's in acute crisis, SPR isn't going to be the thing that you want to use. SPR, if somebody really is at the severe end of the continuum where people are currently in a situation where they are feeling like they're a danger to themselves or to others, SPR is not the thing that you're going to draw on. You're going to draw on the skills you would typically use, the techniques you would typically use to address those concerns. Similarly, if somebody is acutely psychotic or severely cognitively disabled, the skills with SPR are going to be difficult to do. You want to get stabilization first and then think about SPR from that standpoint. In terms of just basic principles of SPR and SPR as an approach for an intervention, it's going to draw on good clinical skills that cut across all kinds of different frames of intervention when we think about mental health. So things like active listening, empathy and validation, all the good clinical skills you typically have where you want to help build someone's strengths and really emphasize their strengths. And again, draws deeply on cultural awareness and cultural humility. When in doubt, ask, and really make sure that the suggestions and specific interventions that you're implementing are fit for the person and their community. SPR does have similarities to cognitive behavioral therapy. So those of you with some background in that may notice that some of those skills look a lot like some of the skills you see in CBT. You're not wrong about that, that's true. It does emphasize skill building. It's going to focus on the present moment, and there is an explicit assumption that there's a connection between thoughts, emotions, and behaviors, which is why intervening on those thoughts, emotions, and behaviors can be helpful. And so with that, I'm going to turn it over to Emily, who's going to start walking us through SPR's components and structure.
Thank you, Kristen. So in the remainder of the presentation, I'm going to talk about what is involved with SPRs. And so what's the content? What do sessions look like? What kinds of things do you cover? And I'm going to give you a general overview today, but next week in our presentation, we're going to get more into the nitty-gritty of what each skill involves and how you deliver it and the kinds of homework that you might provide and what it looks like in an actual session to deliver each skill. So first, SPR begins with assessment. So when you're first meeting with somebody, you need to get a sense of where they are, what their needs are, and how you want to tailor this intervention to them. Because like Kristen said, this is an intervention that's not one size fits all by design. It's supposed to be molded to the needs of the individual in front of you. And you also want to make sure that the person that you're working with is an appropriate fit for SPR. So like Kristen was saying, do they have a different level of need that might be appropriate for a different setting or type of treatment? And I'll get a little bit more in depth about what assessment looks like with SPR in a bit, but just kind of at a 20,000 foot view, you're going to start by getting a sense of needs and concerns, and then triage those needs and concerns into some of these top priorities, and then use those priorities to develop an action plan. And once you conduct an assessment, then you choose from a set of 5 individually tailored skill modules. So SPR is nice because it's kind of mix and match in terms of the skills you use, but also the skills themselves have flexibility to be tailored to different client needs, different cultural backgrounds, different presentations, and the setting and context in which you're doing SPR. So like I said, we're going to go over each of these skills in more detail next week, but I will give you an overview now. So skill 1 is building problem-solving skills. This is something that's similar to problem-solving therapy, if you're familiar with that. It's kind of thinking about how to go through the steps of troubleshooting a problem and reacting in a crisis situation, or when you feel too overwhelmed to handle the problems that are coming your way. The second skill is promoting positive activities. And those of you who do CBT for depression might be familiar with this one because it's very similar to behavioral activation, but kind of stripped down into something that can be delivered even just in one session. So that involves getting a sense of what people, what kinds of positive or valued activities people could be adding into their schedule so that they're not just spending all of their time dealing with crises or feeling stressed out, but making sure that they're making time for the things that will bring them either value or will help them experience positive affect. The third skill is around managing reactions, and these are skills that can be used in a more kind of high intensity, stressful situation to help get through the moment. And these remind me somewhat of the distress tolerance skills in dialectical behavior therapy, but things like deep breathing, for example, mindfulness type skills are involved in that. The fourth skill is promoting helpful thinking, and that skill is most similar to cognitive therapy. So it helps people identify the thoughts that they're having that are leading them to experience negative emotions, and helping them walk through the steps of identifying more helpful thoughts that will then in turn change their emotions. And then the final skill is rebuilding healthy social connections. And this one involves helping people take stock of where they are socially. So who's in their social network, what are their assets and their strengths, who can they go to for support, but also what are the areas that they could use more support, what are the gaps in their network, and what strategies can they use to address those gaps moving forward. So the course of SPR is both flexible and structured. So there's structure to the sessions and there's structure to how SPR is delivered. But like I said, and like Kristen has emphasized, this is something that really is flexible to the needs of the person in front of you. So in your first session, what you'll do is start with introductions, and I'll go into a bit more detail what this looks like in a second, but you'll start with introductions, you'll do some assessment and planning, and then you'll teach and practice a skill together. And then in the follow-up sessions, what you would do is review whatever you assigned as homework in relation to the skill you taught in the first session, and then check back in about how they're doing and how they're feeling and how it was to try to implement that skill in the first week. And then based on that, either choose to teach and practice the same skill again, kind of review it, or choose a different skill to focus on instead. And this gets delivered in the course of about 1 to 5 sessions as needed. Some people really truly might just need 1 session, and some people might need all 5. Probably if you're going for more than 5, maybe a more intensive treatment might be indicated, something like CBT for a mental disorder, for example. But like most standard therapies, the sessions last about 45 to 50 minutes. So in terms of what the actual first session looks like in more detail. So like I said, you would start off by introducing yourself and SPR. So you would talk about what your role is, talk about your purpose for being there if it's not already evident to the person. And then you would give them a background of SPR. So explain that it's a structured but flexible short-term way to help people get through the chronic stage of a crisis, and that there are a set of skills that the two of you will go over and talk about and pick from together based on what you decide that person needs or would benefit from, and emphasizing that that's a collaborative process that you'll do together. And then once you've given them that background, then you'll go on to that collaborative assessment and skill selection. So you'll do an in-depth assessment, and then you will talk together about, given the needs that that person has identified, what skills do they think would be most appropriate. And truly, this is something that people, it's not something that's supposed to be imposed by the clinician on a client. It's something that is supposed to be talked through and decided collaboratively and together. And then once you choose the skill, then you teach that skill. So you'd present a rationale for the skill, and we'll go over those rationales next week. And then you would teach the skill, and then together practice the skill together, which might involve role plays. It might involve doing like a sample exercise together. And then you would assign homework, which would be tailored to the person's needs and the skill that you're learning. And then finally, you'd summarize what you focused on in that session and then discuss plans for follow-up. So based on what they learned, would it be most appropriate to have another session? Do they think they need another couple sessions, or did they get what they needed in that session? And maybe it's okay to kind of wrap up for there or for now and have them check in should they feel that they need more. And then in follow-up sessions, what you would do is start by reviewing the homework where they practiced the skill that you learned in the prior session. And then you would redo the process of collaborative assessment and skill selection. So you would check in about their needs and then together decide what skill you're going to use. And one thing I want to emphasize here is that it's okay to use the same skill that you went over in the first session or the prior session. And that would involve reviewing the skill rationale that you went over in the prior session, maybe applying the skill to a new domain or kind of a new challenge or something that's come up that's leading them to feel that it would be helpful to go over again. And then finally assigning homework. And if you teach a new skill, you just go through the process that you went through in the prior session of presenting the rationale, teaching and practicing, and then assigning homework. And then finally, like in the first session, you summarize and you discuss follow-up. But one thing that I want to emphasize in these outlines is that you're focusing on just one skill per session. So especially when you're working one-on-one with somebody, it would be probably too much content to combine multiple skills in a single session. So now that you have a sense of what this looks like, I hope it's more clear how SPR might be useful for you in your role in the Department of Psychiatry or in UW Medicine as a whole. So it's something that you can use with your clients if they're adults, if they're children, if their families coming to you together. It can be used across the lifespan, but tailored towards the needs of the person in front of you. So if you're working with small children, you can still use a lot of these skills, but obviously you're going to use different language and maybe more simple exercises. You can do it in mental health and primary care clinics. So it's not something, like Kristen said, that needs to be delivered by a specialty provider. And you can do it with either individuals or groups. You could do it one-on-one, but it's possible to get a group together of people that are experiencing the same sorts of needs and then teach the skills to them. And Kristen, Michelle, and I were talking in advance of this about whether it's possible to cover more than one skill for a group or whether you should focus on one skill per session. And probably the same thing applies that I was mentioning with the outline, that it's hard to really cover a skill in depth if you're combining multiple together. But if you're just giving a brief overview, sort of like what we're going to be doing next week, of general coping skills, and it's not something that somebody's come to you for help and you're wanting to give them personally a set of skills, you could do a broader overview of more than one skill. And then finally, like Kristen said, this is something that we can apply as self-care in our role as providers as well. So next I'm going to give you an overview of what it actually looks like to do an assessment in SPR. And that's the one skill we'll focus on for today. And then in the next session, we'll go over the remainder of the skills. So the first step of assessment is identifying people's needs and concerns. So it's implicit in this, like with all the other skills that you're presenting, that you start off by providing the rationale for doing this assessment, explaining why you're gathering information, and tailoring to the person that you're working with in that explanation. So you might say that after a crisis, there's lots of demands that come up, there's lots of concerns that come up, and you need to gather information to target the support and tailor the support to that person. and maybe you're assessing, does, you know, the person need a referral to a higher level or different type of care? Maybe, you know, what they need is not a full session of something. Maybe they're actually doing okay, like especially if you're presenting to a whole group. Maybe some people, it's not a great fit for them. And one of the things that has come up with some of the psychological debriefing approaches, for example, is that truly not everybody needs to be taught coping skills. Some people are managing fine on their own, you know, maybe at particular moments in time, maybe at another point in time, those people will have more trouble. But it's not always helpful to really harp on distress and how people should be coping when people are coping fine on their own. And then once you get a sense of the level of care that's needed, what you want to do is get a sense of what people's main needs, concerns, and priorities are. So you want to think about, you know, when you need to make a referral. And Krista noted some of these reasons, but if somebody's primary concern is more physical health related, like if they have an acute physical health problem that needs attention, it probably isn't the time for SPR. If they're having a lot of safety needs, if they're having acute psychosis, or if they're cognitively impaired in a way that would make it hard for them to comprehend the content of the sessions, that might not be appropriate. And then if they have an acute mental disorder. So next, what you would want to do is, given the information you gathered as part of the assessment, prioritize the areas that you want to address. So you could ask things like, you know, of these things, what do you want to work on? Which of these problems is bothering you the most? If there's a lot that's bothering them, is there one that's getting worse? Is there one that needs to be dealt with sooner than the others? Is there something coming up in the near future that it's important that the person feels prepared to address? And so work together with the person, again, focusing on the collaborative piece of this to rank the concerns together and pick one to focus on in that session. And then the final step to assessment is collaboratively making an action plan. And what you'll do with that is choose the most appropriate SPR skills to use. And on the next page, I'm going to show you a handout that we adapted from the National Center's handout that is kind of a skill picker. So given people's needs, what skill would be most appropriate. And that's something that we've made available online for you to use if you choose to use SPR with your clients. And then what you'll want to do next is agree on a tentative number of meetings. So this is part of the structured aspect of SPR, that you don't really want to leave it open-ended. You want to give people kind of an idea of what they can expect in terms of the number of sessions that will be needed to address their concerns. And then finally, you'll want to make referrals if needed as part of the action plan. And making these referrals in part is knowing what resources are available to you. So the three of us in Trauma Recovery Innovations joke a lot about Molly Forrester is so incredibly helpful and knows all of the resources, and she's our go-to person for knowing what's out there. And so I think in every presentation we've done about this, we've said that everybody needs to have their Molly. They need to have a person that they can call upon so that they don't have to have all the information about referrals and resources in their own head, but they can consult about that. So this is the skill selection tool that I mentioned, based on the one from the National Center for PTSD. So in the left-hand column, it has the concerns that you might identify in an assessment, and then the middle column is the kind of go-to skill for that concern, and then there are also some secondary skills if the primary skill maybe isn't a good fit for what the client is presenting to you for some reason, or if they don't seem to be interested in that skill, there's also backup skills. So people that are having difficult but solvable problems, it makes most sense to do problem solving. If people are having a lot of really intense or upsetting reactions, and managing reactions makes sense. If people aren't knowing how to connect with friends or family, or don't feel like they have enough people that care about them, then social connections make sense. If people are feeling depressed or down, healthy activities make sense, which tracks because that is one that's similar to behavioral activation. If people are having a lot of upsetting thoughts that are leading them to feel negative emotions, then the helpful thinking kind of cognitive approach makes sense. If people are having a serious physical, mental health, or substance abuse problem, again, it's important to make a referral, but in certain situations where it does feel appropriate to manage that in a session, problem solving can also be useful. And then if people are experiencing a lot of current hardships or adversities, again, problem solving with referral can be something that makes a lot of sense. So before we turn it over to questions, just some last thoughts and resources. And the first is that resilience is messy. So I think a lot of our clients, can come to us and feel a lot of judgments about their own coping with trying to be resilient or coping with the things that are coming up, and really just emphasizing that it's okay to not be okay, and it's okay to struggle to know how to cope. And a lot of the things that are coming up are calling upon us to really be nimble and adapting our coping strategies to ever-changing circumstances. And that's just part of the process, and it's a feature. It's not a bug. It's something that we expect, and it doesn't mean people are have something wrong with them or are doing a bad job. So this quote says it's to be adapting and accommodating rather than resistant to the suffering. That's what it is to live through hardship for sustained periods of time. So it's not that you feel no distress. It's not that you have no problems coping. It's that you are adapting and accommodating to what comes up. So finally, I just want to highlight a few resources. So the manual for SPR is available online through the National Child Traumatic Stress Network via that web link. And the National Child Traumatic Stress Network also has a free online training that is useful. And then through the Department of Psychiatry, we and others have put together some resources for clinical care and for providers related to dealing with COVID and responding to clients that are dealing with hardship resulting from COVID. There's also a COVID coach app through the National Center for PTSD that I've heard good things about. And then finally, Washington Listens has some online resources, and it has a non-clinical support line. And those might be good resources for either you or the people that you're coming into contact with. So with that, I'm going to turn it over to questions. And so if you have questions, please feel free to post them in the Q&A.
And Emily, there is a question for you and Kristen in the chat already. If you want to take a look at it, it's about how we measure resilience in different studies, whether it's self-reported measures of stress or something different, and then also how we define resiliency kind of more generally in the literature. And that one's in the chat, and I think both the question and answer and chat functions are open for other people who have questions they want to chime in with while Emily and Kristen are answering this first one.
Great. Emily, you want to take that one first?
Yeah, I'm not sure that I have a great answer for this. I think that, SPR, for reasons that Kristen mentioned, has been understudied in terms of its impact on resiliency. So they've mostly studied it in terms of the kind of implementation side, so how useful or helpful it's been to providers. But I know from the more general kind of traumatic stress literature that people define things like, post-traumatic growth or the absence of psychological symptoms as being part of resiliency. Things like quality of life also can come into play. So that's my perspective on it. Kristen, I don't know if you have anything else to add about that.
Yeah, I guess what I would say is that when we think about SPR and it being studied more from a dissemination and implementation standpoint, then what the data that you end up getting is a lot more what do providers think about it, what happens at the clinic level versus how do patients or clients or respondents specifically react to it. And then when you think about resilience studies more broadly, you might have general measures of anxious and depressive symptoms. You might get measures of functioning. And then sometimes you get measures that have been developed related to well-being, looking at, for example, like satisfaction with life, social support pieces like that. And so that's where a lot of those data come from. And this is one of the challenges, quite frankly, with the space. And part of why we liked SPR is because it is this really kind of, if you will, like a transdiagnostic approach, not that we're necessarily thinking about full-blown mental health disorders, but thinking about a whole range of kinds of problems that people would be experiencing in response to a crisis, in response to disasters.
And I think the only thing I might add is, you know, with the resilience literature, there is also always discussion around should we be looking for, you know, blips in functioning that are then shown to be returns to baseline functioning? Is that what it means to be resilient? Does it mean not having a reaction at all? And there's quite frankly quite a bit of debate in the literature about that. But I think for the most part, it's generally accepted that what we're looking for is some sort of pattern where over time individuals come back to something that looks something like where they started before the stressor happened. And they're able to do that sort of bounce back process that we often think of as being resilient. So not having no reaction, as Kristen and Emily talked a lot about, but instead having that ability to keep moving forward in some, you know, in a meaningful way, in a way that looks like it did pre-stressor in some way, shape, or form. Yeah.
I think part of this too, something that I have found is interesting in prospective studies following trauma is, you know, you do often see kind of a high level of initial distress that comes down, but you also see people that never experience that initial blip in distress. And you see some people that maybe were doing poorly before what happened, and they actually have improvements in functioning after a major life event. Maybe sometimes because it puts things in perspective, or it kind of engages some of their coping strategies. And then other people go through something and are affected by it, and not just their symptoms go away, but they actually kind of develop new perspectives on life, and maybe they strengthen their relationships with their social support, and they strengthen their coping skills, and all these things give them this sort of what we call post-traumatic growth that actually leaves them better off in some ways than when they started, psychologically speaking. So it's not just the absence of distress, but it can also be kind of the addition of some more positive things, as Michelle and Kristen alluded to.
I don't see any more questions in the chat. I'm wondering if I might ask a question. Do you have experience or know of the use of SPR in a hospital setting, on like a consultation service, for example, or even on a psychiatry service, while doing acute treatment for a mental illness?
I think Doug Zatzik would be a great person to talk to about those sort of approaches. And I think he was on the in the audience a bit earlier, but there have definitely been efforts to implement acute responses to, or acute interventions for trauma in medical settings, and those interventions have had positive effects. I'm not aware of any efforts to implement SPR specifically in hospital settings, but a lot of the interventions that have been used are similar in a lot of regards, in that they're drawing on CBT type principles.
Okay, well, thank you very much for part one, and we'll all look forward to part two next week with the brief summary, as you said, and then moving forward with skills and application. Yes, Doug just wrote a comment. Yes, we start with asking about general post-traumatic concerns. I see. Okay. All right. Well, thank you. I guess we'll just stop the video as the way to end. So,
thank you all.
And we'll meet back up next week. Thank you.
Thank you.
Thanks, everybody.
Bye.